So welcome to the Gynecologic Initiative, Cancer Initiative Special Research Rounds talk. My name is Andrea Nielsen. I'm a gynecologic oncologist and researcher at UBC. First off, I'd like to take some time to acknowledge the traditional and unceded territories that we are each joining from today. This is the hybrid research rounds model, and we have people joining from many places. For those of us who are in the room, we are joining from the territories of the Musqueam, Squamish, and Tsleil-Waututh nations, and I invite you all to take some time to acknowledge these territories that you are joining from today. We'll jump into some housekeeping. For those who have joined us in person, please note that we have some lunch and beverages at the side of the room. Vegetarian, gluten-free, and dairy-free options are available. Please feel free to help yourself. During the Q&A session in this room, please use the microphone nearest to you, and ask your question It is already unmuted. For those that are joining virtually during our Q&A session, please feel free to use the chat function or raise your hand function to speak. So without further ado, I'm excited to introduce Dr. Leah Norgrove. Dr. Norgrove is a family physician and palliative care specialist practicing in Victoria, British Columbia for over 30 years. She's been recognized for her compassionate approach to end-of-life care, particularly her work to improve palliative care services for Indigenous communities throughout the SÁNEĆ Journey Home project. This initiative seeks to value Indigenous ways of knowing and foster culturally safe palliative care for First Nations patients at Saanich Peninsula Hospital. Internationally, since 2009, Dr. Norgrove has supported clinical service development in Tanga, Tanzania, co-founded by the Bombo Palliative Care Project, and helped to implement a cervical cancer screening program in 2016 in response to the undue burden of this single diagnosis. In 2018, she received the Canadian Society of Palliative Care Physicians Humanitarian Award for her contributions. She is currently enrolled in the Clinician Scholar Program at UBC, seeking to bring a research lens to her work in Tanzania. Thank you very, very much for joining us today, and I will pass the microphone to you.
Thank you, Andrea. And thanks to whoever, for maybe Almira, for the invitation to share my global health research journey today, which is focusing on cervical cancer screening and treatment in Tanzania. I really value all of you being here, your interest and engagement. I noted on the GCI website your vision and mission, which is we protect and save the lives of women, mothers, grandmothers, sisters, and friends. And I know how hard it is to take the time to think about another set of cancers on the other side of the world. I have no disclosures. As Andrea said, I'm currently enrolled in the Department of Family Practice, the Clinician Scholar Program. I'm fortunate to have Dr. Gina Ogilvie as my mentor, who you probably will know of, at least for her enormous contributions to the changing landscape of vaccination and cervical cancer screening in BC and Canada, as well as her global work in Uganda and Rwanda. I've listed a very few of our collaborators in Tanzania because, of course, they're the ones doing the work. And at the bottom is Dr. Ambrose Marsh, who is my husband and is also a family physician. And, you know, our work on all of this is very much a duo affair. And so while I might be the kind of nerdy academic one, Ambrose is the yes person. And I'd just like to point out also we have some beautiful African fabric napkins for sale, which go to supporting cervical cancer screening in Tanzania. We started a small not-for-profit society here in BC to generate funds to support both palliative care and cervical cancer screening, and that's our logo there. So at the end of this presentation, you'll have been exposed to cervical cancer as a global health issue and to the WHO elimination strategy and its concept of the third bubble of treatment coverage. I'll talk about that. And just the significant challenges of measuring screening outcomes and the treatment cascade in Tanga, Tanzania, where we work, and lessons learned from this research project about the Tanga data set that have helped to set the stage for next steps for research. So we're now 15 years into a funding and mentorship relationship with Tanga Regional Referral Hospital, which going forward I'm going to call Bombo. And the reason for that is that's what it's colloquially known as, and it's just a lot easier to say. When we first arrived in 2008, we were invited to introduce palliative care, and the HIV rate at that time was sort of 8–9%. It's significantly better, but it's still too high at sort of 5 to 6% now. We spent 6 months there as a family from in 08–09. And of course, co-infection with HPV and HIV contributes to an increased burden of cancer of the cervix. We began to witness a shift even in our own little program of comorbidities. And since 2016, we've had really a dual focus on palliative care and cancer of the cervix. So why this dual focus? Well, I had a couple of family practice residents in 2017 who reviewed our diagnostic data from the palliative care program at Bombo. And over a 1-year period between 2013 and 14, there were 100 female deaths, and cancer diagnoses were responsible for half of them. And of those, 60% were due to this one single diagnosis. So overall on the program, 30% of female deaths were from this one single diagnosis. So this is a really unusual palliative care profile. This seems to not go. So of course the findings of our tiny little palliative care program is very much replicated in global health data. And I'm going to give you a few slides to just sort of get your understanding of what a significant problem this is. So on the top there, the blue is incidence and the bottom is mortality. The darkest shade is countries, are generally low middle income countries with very high incidence and mortality. On the right there is looking at just this cancer diagnosis, and at the top, Eastern Africa having the highest incidence as a region, and then the lower yellow arrow being North America. So honing in on Canada and Tanzania specifically, such a different cancer profile. And you can see that incredible dominance of cervical cancer on the right with an age standardized incidence of 64.9 in Tanzania and 6.6 here in Canada. And this is Canada's profile of decreasing incidence over the last 50 years. And I've been a palliative care physician for 30 years, and I rarely look after a woman these days who's dying of cancer of the cervix. And when I do, I always meticulously go through her cancer clinic records and try to figure out why this woman is dying on it in this era. And always there was the history of a mildly abnormal pap smear 10 years ago, 12 years ago, that, for either a systems reason or a patient reason was not addressed. So, for sure, we have it confirmed that this curve is because of the introduction of a well-organized pap screening program, 5 to 6 decades ago, actually. So what does it mean for Tanzania, this incidence of 64.8 for a healthcare system? So the absolute mortality annually is nearly 7,000 women in Tanzania. So much more significant than any other cancer. And these women are in their 30s and 40s and 50s and 60s at the peak of reproductive years, parenting, caregiving, working, with corresponding massive socioeconomic consequences. And due to an entirely preventable epidemic, we have the tools, and this is therefore considered the largest cancer equity issue for women worldwide. A final comparison with Canada, so 1,600 new cases annually here with a 75% 5-year survival rate, so 400 deaths, whereas in Tanzania, over 10,000 cases and a mortality, as I said, of close to 7,000. So we don't have historic data for Tanzania because that's part of the problem. There's no cancer registry, etc. And you can see, though, this is the modeling of the projected curves of incidence and mortality in Tanzania. So we're not done yet. Then from the WHO, globally, 1 woman dies of cervical cancer every 2 minutes. 9 in 10 cervical cancer deaths worldwide occur in low and middle income countries, and women living with HIV are 6 times as likely to develop cervical cancer than women with HIV. So all of this has inspired the development of the WHO strategy for the elimination of cervical cancer. Imagine elimination of a cancer. It's a remarkable thing to say. Of course, we think of smallpox and polio, not cancer. And of course, the reason we can think about elimination is because of the unique etiology of HPV infection in oncogenesis. And that there's this protracted period of time of persistent infection that's required for HPV infected cells to develop into high-grade dysplasia and cancer. We have, in response, we have excellent vaccination options. We have very effective screening strategies to interrupt this long progression to cancer. And we have effective treatments for precancer and for early invasive cancer. So this is the strategy, 90-70-90, and these particulars are for the elimination strategy by 2030. So 90% of girls vaccinated with HPV vaccine by age 15, 70% of women are screened with a high performance test by age 35, and then again by age 45. And I'll just focus on that one for a second. So this, of course, is we're just introducing now in Canada. And I think our elimination strategy is more like 2040, 2045. And we're very far away from this in low and middle income countries. And most of these countries have followed the previous WHO strategy, which was to introduce the screening tool of VIA, visual inspection with acetic acid. And Ambrose and I are old enough to remember learning to apply vinegar to the cervix when we were doing pap smears when we went to medical school. And so this is a visual tool where the dysplastic areas blanch aceto white, and you can visually grade lesions then as small to moderate, large, or looks like cancer, called suspect cancer, which would have different described findings. And so this previous strategy was a screen and treat strategy. So screen women with VIA and be able to treat right there that day for small lesions with cryotherapy, more contemporarily in thermal coagulation. And that's an extremely effective strategy. As soon as women have to leave and come back on another day, we lose them to follow up. So that's just a little bit about what's going on in low and middle income countries and how far we need to come before we're introducing the high performance HPV DNA. And the last bubble is about treatment. Is then, okay, 90% of these women who we identified through screening receiving treatment. So 90% of precancers treated, as well as 90% of women identified with cancer treated and managed, including palliative care when women present with advanced disease. So in response to this epidemic, and I should just say, by the way, I'm not focusing on the very sort of popular HPV DNA. I'm focusing in that third, difficult to wrap your head around treatment bubble. So in Tanzania, back in 2011, their national screening cancer prevention and control was introduced in 2011. Tanga is one of 31 regions or provinces in Tanzania. And the introduction was very piecemeal to over 300 sites by a sort of generally university-based global health, pilot projects. And there was no screening introduced in Tanga region. And as I said, this was a VIA-based program, this screen and treat. And at Bombo, the hospital where we work, CCAP was established then in the CTC. So CTC stands for Care and Treatment Center. And that is basically the name given to the organization of HIV care across Tanzania. And this was only introduced in 2008 when finally antiretrovirals became available to East Africa. And so both because that's where our partners were, but also because that's where the most at-risk women were, but also because it was some kind of a primary care structure that we could attach screening onto. And really, there are no other kinds of primary care structures, no other screening for other cancers, no mammography, no FIT testing. And those CTCs are starting to do some longer-term follow-up of hepatitis and TB and some cervical cancers. But immediately with the introduction of this program, the challenges of knowing what was happening, the efficacy of the program, and tracking what happens to women when they have a positive result was immediately apparent. So for the non-clinicians in the room on the left, this is a normal cervix. And for the gynae oncologists out there, I think you'll be horrified to, for those of you who do colposcopy to realize that this is the level at which we are recognizing and grading precancerous and cancerous lesions. So this is on the right, a VIA positive findings after vinegar has been applied. And so these lesions are visually graded into small to moderate, large, and suspect cancer. Small to moderate get same-day cryotherapy. Large get a need to come back for a leaf biopsy. And suspect cancer gets a tissue biopsy. So these are a couple of nurses who do VIA. They've done hundreds and hundreds of screening exams. Sometimes they do 20 in an afternoon. As a family physician, I can't imagine doing 20 PAPs in an afternoon. And they would identify small lesions and treat with cryotherapy, and otherwise inform women of the findings and encourage them to come back for a leaf or biopsy. And so how is Tanzania doing with this WHO strategy when we try to? So this was the country profile, the most recent one on the WHO website. So that vaccination bubble to the left, they're actually not doing too badly. Vaccination was introduced in 2018. So 4 in 10 girls had received both doses of their final vaccination. I understand that it's something like 80% that have now had at least a first dose. But very limited screening engagement. So only 1 in 10 women have been screened for cervical cancer with VIA in the last 5 years. And really no specific data about this target of 90% of pre-cancer treated. And so I began to think about how can we use our own data at Tanga? How can we think about evaluating the treatment cascade that falls from a positive VIA finding? So after those encounters or during encounters, they enter the encounter data into these keeper ledgers, which are the same across the nation. This is the National Screening Ledger. And much information is collected: demographics, age, parity, HIV status, and they have opportunistic testing for HIV embedded in the screening for those women whose status is unknown or want to. And that's a very positive thing. Many countries in East Africa have very sort of standalone HIV screening and cervical cancer screening. And then the encounter data and follow-up data of what happened with women who had an result. Very quickly, we realized we needed to have a biopsy ledger as well, because Tanga, the Bombo, where we work, is the regional referral hospital. So regional referral hospitals are the only place you can get a biopsy or leaf. And so as the screening program started to unfold with satellite screening sites outside of Bombo, women started to be referred in from other screening sites. When we first started going back after that introduction in 2016, I would pore over these ledgers or these massive big books with just pages and pages and pages of data like this. And, my family practice heart would sink as I looked at the results and would go over with a provider, well, what about this woman? What happened to her? What about this woman? How come she didn't get same-day cryotherapy, et cetera, et cetera. And so, you may ask the question, why on earth would you want to drag through this giant paper ledgers? But the reality is this is all we have. There's nowhere else that this data is recorded. There's no other way of knowing how we're doing. And that concept as a family physician of chart review and your, sort of your responsibility to a population and to screening in your practice is, it's very well understood and taught here, but not there. There are no other screening activities. So my first project in the CSP program has been to develop the Tanga data set out of these paper ledgers. And so that required scanning and both the screening and the biopsy ledgers, and then developing a data dictionary, which data we were going to record and enter into the Excel spreadsheet, cleaning up very unclean data. And then we tried to merge screening visits with biopsy visits and try to see, women who had come in 2016 and then they came back for a second screening in 2018 and follow a woman's screening journey along. And that proved extremely difficult. One of the reasons was because women don't have dates of birth. They just report their age. And also they often have sort of triple barrel names and they might be given in a different order and there might be a spelling mistake in one. And so it was very hard to search on these. We did our best. I think about 40 people we managed to map in that sort of way. And then of course, de-identification of the data and looking at what happened and mapping out how well we were doing with linking positive VIA to the prescribed treatment. And as I said, we became more and more aware of the regional role of Bombo and other screening sites referring in. Lots of limitations, legibility, a big problem, really idiosyncratic ways that providers entered their data, transcription errors in the data entry, lots of empty fields, et cetera, et cetera. So I'll just show you an example of on the left, there is a well filled out ledger. So the column to the left of the pink is where the VIA outcome is written. So number 3 is a normal cervix. Number 1 is a small lesion. Number 2 is a large lesion. And number 4 is suspect cancer. And so where I have the green there, you can see that those 2 women who had a suspect cancer outcome received a number 5, which is the ledger up there is in Swahili, but it is that they received a biopsy. And then the far right shows the arrow to Muhimbili Hospital, which is where they would be referred for staging. They had confirmed cancer diagnosis and they were referred. And that is an 8-hour bus ride away in Dar es Salaam. So all histopathology goes to Dar es Salaam. The one above with the green dot is sort of, a small lesion that received same-day cryotherapy. By contrast, on the right here, we have 2 number 4s that have absolutely nothing written in the column beside. And so this is a woman who would have had a provider say, oh, this looks like cancer. You need to return for a biopsy. And that was the end point. She's lost a follow-up from that point. So you can imagine the sort of ethical discomfort. And just a side note, the purple dot, this would be a woman who wasn't eligible for VIA because there was no visual squamous-columnar junction. So this was, of course, done with all ethical clearance from the National Institute of Medical Research, including a data transfer agreement so that the data could be evaluated in Canada. So what are our primary outcomes, and UBC, what are our primary outcomes of interest? So 3 areas, sort of descriptive statistics. Who was this group of women? And, what was the nature of the screening encounters? The second light green being, what were the results? How many women had VIA positive results? And what were the rates of precancer and cancer? And then finally, really where I'm focusing is the engagement of women who had a VIA result in the appropriate treatment cascade. We also did some, association evaluation for various variables such as HIV status, screening year, to see if the correlations could be found with how well, for example, they engaged with the treatment cascade. So, for example, are women living with HIV who screen VIA positive more likely to engage with the prescribed treatment cascade? Yeah, a question that I would ask. So very basically, I'm not going to spend much time on this, about 2,300 encounters, 70% were women living with HIV, lots of pregnancies, so lots of children. That is a major barrier to leaving to get cancer treatment, for example. So this was largely an unscreened population, 83% having their first lifetime screen. And in the biopsy data, 357 biopsies generated for suspect cancer, 2/3 of those living in Tanga and the other third being referred in. HIV status, unfortunately, not comprehensively reported. But we did find that women living with HIV were more likely to receive LEAP and biopsy than HIV negative women. And that's because there are enormous unfunded aspects of the healthcare system, including LEAP and biopsy. But at periods of time, there are, generally partner international NGOs that fund HIV positive women or women living with HIV preferentially. So then what happened? What did we see in terms of VIA positivity? That's the green bubble there. So pretty easy numbers, 3% had small to moderate, 2% had a large lesion, and 5%, more than the other two, had suspect cancer. So, probably because we're screening a largely unscreened population, I thought. So what's to happen when a woman has a positive VIA result? If she has a small lesion, as I said, she's to get same-day cryotherapy. A large lesion requires LEAP. Suspect cancer requires a biopsy. Then that biopsy needs to get to Dar es Salaam, and the results need to get back and delivered to the woman. And I'll talk about that in a second. And then those women who are diagnosed with cancer need a referral from Bombo to get to the Ocean Road Cancer Institute, which is also in Dar es Salaam, an 8-hour bus ride away. Or if they're presenting very late stage disease, they need palliative care. And of course, then getting esoteric care, do we know that they received cancer care? And, obviously long-term longitudinal follow-up. And just for your knowledge, there are no cancer registries in Tanzania for any cancer. So, so then we started thinking about the refining. Okay, what could we learn from this Tanga data set? And certainly we can measure engagement in same-day cryotherapy. And then also there was a way in which you could look for women who came back another day to get that cryotherapy that they didn't to that day. And completion of LEAP for large lesions, completion of biopsy, results of biopsy shared with the patient, and women with earlier unknown stage cancer diagnosed receiving a referral for cancer care. And as I said, women with advanced disease receiving palliative care. So the data analysis, it sounds kind of simple, and it is really what I would call common sense statistics, but there is actually a WHO manual developed to identify retention gaps in complex care cascades. So it was developed, of course, for HIV care, which is also a super complex care cascade. This happens, they need this. If this happens, they need that, etc. And so they call it a changing denominator or target approach. And so we use that to calculate the cancer of the cervix prevention and care cascade following these screening encounters. So, put simply, all women in the Tanga data set who reach a given step comprise the denominator for each subsequent step. So if you have 100 women screened with VIA, 10 of them are going to be VIA positive. Of this 10, then 5 becomes the new denominator who had suspect cancer. Of those 5, then 2 got biopsies, et cetera, only 1 got her results and 1 got a referral for cancer care. this kind of idea. So that's the framework. It's pretty obvious. But in this way, though, treatment gaps in the care cascade are defined and quantified. And those women who don't progress to the next step are presumed lost to follow-up. That's the only assumption we can make. Now, of course, maybe this data is the worst case scenario, because just because it wasn't entered in the ledger doesn't mean that a woman didn't get that correct treatment. But it is, as I said, all that we have to go on. And certainly when I asked, lots of times, well, what happened to this worker? Well, she didn't have the bus fare to come back. She couldn't pay for the biopsy. Sometimes her husband wouldn't let her, whatever. So this is a very synthesized version of what was important. So same-day cryotherapy. In this first 3 years of screening, only 57% got same-day cryotherapy. Another 3% we could identify, so maybe 60% altogether, like where women came back and got same-day cryotherapy. However, what I would say is that when we looked at it year to year, by 2019, things were much better. It was approaching 80%. And so I'm not so worried about this particular outcome. And so the far top green bubble, LEAP completed for large lesions. So only 40 large lesions identified in 3 years, 48% got treatment. Only 64% of women who had suspect cancer finding, so 176 out of 118, got a biopsy. And then the next bubble, only 16 or a full 16%, we have no record of that biopsy, no knowledge that that woman got that result. Just, sort of even worse, this woman comes, has a biopsy, and then we don't manage to go the next steps. And of the biopsies that were done, 90% are positive for cancer of the cervix. So again, teaches you about, way too many false negative results with VIA, and, poor sensitivity. But on the other hand, 269 women were diagnosed with cancer of the cervix in the first 3 years. Half of them got a referral to Ocean Road. And despite it being under the same CTC umbrella, we just really didn't track whether women received palliative care or not. So we returned in March and shared the preliminary results of this Tanga data set, with providers, with the gynaes at the hospital. There's now 4 of them, with the hospital leadership, and also with our wonderful new NIMRE research partners who are right on site at Bombo Hospital, and began to ask, the question of what we could do to improve this. So I'm kind of moving into the last part of my presentation, which is about, okay, how can a research lens be brought to helping to improve this situation? So we had conversations with all those folks, tried to really understand, from narratives of what the issues were and what the process is like for a woman. So I'm gonna share that with you. Oh, I guess I should have said also, conclusion, it's really fractured between screening outcomes and access to treatment. And why is that important? This should be too intuitive for a well-developed healthcare system. Screening women without access to treatment is unethical. These are WHO statements. Cervical cancer screening will require a matching increase in capacity for treatment of all the detected lesions. And we need to align our treatment plan with what's available, in this case, in Tanzania, and in low and middle income countries. It's very different, and a context-sensitive approach, not imposing something that's not developed from the community and culture. This is from the WHO, which is sort of a stratification of well, not really stratified, but a list of all the things that need to happen to make comprehensive treatment available for women So I'll just talk about a couple of points to give you a bit more info. So that first one, implementing cervical cancer guidelines, that happened in Tanzania in 2021. And Ambrose and I always go visit Ocean Road when we go, and we have an oncologist connection there. And they're now have an electronic medical record, and their cancer guidelines are almost wholly combo chemoradiation. There is unfortunately very little surgical capacity or investment in expanding surgical capacity for hysterectomy. And that third bullet, strengthen pathology services. I'm going to tell you a story. When we first started, we're first asked to help implement cervical cancer screening. It was from the late Dr. Mutati, who was the medical officer in charge and the gynae, the only gynae at the time. And he approached us with his handwritten ledgers of all the women he had diagnosed with cervical cancer, literally with tears in his eyes. And he told us that it took at least 3 months for a biopsy result to come back, and often didn't come back at all. And what was pretty quickly implemented when we started screening and all these biopsies needed to be done was a much better system, which was that the hospital driver took 2 weeks of biopsies down to Mumbai and then brought the last 2 weeks of results back. And that has worked extremely well. We were shocked to find out when we returned in March that now the biopsies come back electronically to the lab at Bombo, which is great, you know, piecemeal, a little bit like our country, not very well organized. Electronic record keeping is happening, but it does have big ramifications for ensuring that that result gets to that woman. And so just to say, pathology services are an incredibly tight bottleneck in Tanzania for being able to scale up the screening and treatment. So, and just to give you the regional picture, just a reminder, that's the country of Tanzania. On the left, the red is the region where we work, and on the right, that region pulled out. So we work in Tanga City District, where the big regional hospital is, but there are these other 8 regions that are incredibly rural. 75% of women live rurally. But what's also happened is that there are now 44 screening sites across that region. About 80% of them have the ability to do same-day cryotherapy. These providers have all been trained in VIA, and some are using thermal coagulation instead of cryotherapy because you don't have a tank and gas and everything. And so there is a coordinator of Tanga region, but there is for screening, but there is no coordination of treatment. But our role at the hospital is as the place where women come for biopsies and the only place where they can get a referral to OSHA. And that is like a national thing. So in our conversations and with providers and clinicians and researchers, you know, and taking that in the context of this regional role, we had decided to focus on establishing better care pathways and referral networks. And close to our hearts is, of course, re-strengthening palliative care, which took real hits through COVID. And, you know, by strengthening those referral process, we will improve access to cancer care from Tanga region. It doesn't improve things across the country, but this is sort of gives you a conceptual. So we also realized, okay, that was 2019. Things have probably changed a lot. So Ambrose and I did a quick tally snapshot of 2023 to see if things were still so bottlenecked and such a problem. So about 1,400 screening encounters in 2023, 80% women living with HIV. And overall, the frequency of VIA is down to 5.6% of visits. But 4% to 4.7% of visits have the finding suspect cancer. So if you go down to the bottom, very few number 2s and number 1s, you know, in the order of less than 1% or 1%. And only one of the, only one large lesion or two large lesions, only one gets a leap, like really scary results. And then of those 65 women who had suspect cancer, only 26 thought of biopsy, so 40%, and 26 confirmed cancer again, so 92%, and 37.5 that are referrals. So we still have work to do for sure. And why so few precancerous lesions? Well, one thing that had really changed is that while overwhelmingly the last data set was first lifetime screen for women, now we're seeing women are coming back 3, 4, 5 times. So we're screening the same women over and over again. This would be a perfect opportunity to introduce HPV DNA and then only do VIA on the women who are HPV positive, and save those other VIA resources who've never been screened. That 9 out of 10 not been screened. I'm going to finish with a narrative of a woman attending Bombo. So she may have come to get her antiretrovirals, and she is learning opportunistically about the need for cervical cancer screening. So say she came and got VIA done, she might live in a house like this on the left, and she might travel in a bus like this to come get her screening or come get her follow-up. And if she came from a regional clinic, this is a different clinic in Gamiani, which is a large sort of primary care clinic in Tanga city, not too far from Bombo. So she had a VIA small lesion. That's the cryo tank there in the silver with the turquoise, gun-like thing with the cryo probe. So she could get her cryotherapy where she got her screening. But if she needs a leap or a biopsy, then she needs to come into our facility. And if she needs a leap or a biopsy from one of those distant districts, the barriers start to quickly mount. So I just wanted to tell you a bit more about the unfunded costs of the treatment cascade. So a biopsy costs 80,000 shillings, which is about $30 US. I looked this up, the estimated monthly living wage of a typical family in rural Tanzania, and living wage being defined as basic but a decent standard of living, is about 460,000 shillings a month. So that's the family living wage. So about a fifth of the family's wage would need to go to paying for her biopsy. And of course, many, many women live in settings where available family wage is much, much lower than that. So the fact that they're unfunded is a big problem. And it's in fact what our small little not-for-profit society has done a lot of over the last few years. And a leap costs like 42,000 shillings. So also, if she needed cancer care, she would need to be able to go an 8-hour bus ride away to Dar es Salaam. That's the picture on the right, one of the blocks of Ocean Road Cancer Institute. And sadly, in 2023, they have introduced a cost-sharing scheme. So they may have brachytherapy now and MRI and CT that they're very proud to show us, but it now have introduced a cost sharing for both staging, workup, and for cancer. This really leads to, okay, what are the barriers and enablers to treatment to fix this problem? This could be a 1-hour talk on its own, and we can understand a lot just from speaking to the local patients and providers. And many surveys have been done in many other East African countries about this, financial barriers being paramount. But I did do extensive research, just, seeing its relevance to our setting. And certainly, the barriers can be sort of understood on a client, provider or system level, and other things like weak linkages to treatment, lack of effective service delivery models, et cetera, et cetera. There is unfortunately significant stigma that still exists in Tanzania, and Also a repetitive social cultural belief that I read about, that receiving the diagnosis leads to death, almost in a causation kind of way. And that makes sense because most women are presenting for screening when they have symptoms and they have advanced disease. And so any woman they know to Dar es Salaam has died. And so there's also a real sense of futility about persevering and pursuing. So a lot to be unpacked there. Also, like added to the Let's Search about, you know, what other places we're doing around screening, scaling up screening treatment. This middle one, you guys may know more about this, was about novel diagnostics that are being developed because of this. And this is early, like they're just being developed, not really trialed yet, but a concept that you could do a swab, let's call it a swab, and not only detect whether you are infected with a you know, whatever it's called, HPV strain, but also whether you have high-grade dysplasia or cervical cancer. And this would be a wonderful tool to sort of bypass this massive biopsy problem. I think I'll just persevere. This last couple of slides is about where we've landed, which is to look at introducing a treatment coordinator, including with patient navigation, primarily a patient navigation role for cervix disease identified through the CCAP Cascade. So this is and this is to ensure that women identified with cervix disease are supported through to treatment. So this is a figure of our patient flow diagram, and the orange areas, don't try to read it, the orange areas sort of represent cervix disease navigator activities to help you know, contact women who a month after they've been told they need to come back for a biopsy, haven't come back, haven't engaged. And then, you know, sometimes that intervention might be education, and that's all that's needed. Sometimes it may be a social assessment around the need for funding, et cetera, et cetera. So I'm working on this together with my research partner in Tanzania. And so that's the plans. And just to finish, I just wanted to say a thank you to my original family practice preceptor, Dr. Betty Kalem, who is a family practice researcher here in Vancouver. But I had the good fortune to fly on her coattails in Haida Gwaii back in 91, 92. And just by way of saying, like, as I reflect on this, I see how many seeds were planted at that time about, you know, about screening and the role of, you know, having that population-based lens and equity issues that weren't called equity issues at the time, you know, cultural safety that didn't have that name at that time, and just sort of, you're all young and just, you know, thinking about the role that preceptors play in shaping our careers as they end. And thank yous to the people who have helped me with this first analysis of the data.